get going, and then we can get through all the questions that we've got planned for today, which are brilliant. So hello and a very warm welcome to this discussion. My name is Joanna Taylor and I am Laura's business coach. I've been working with healthcare brands like Noi Group, Pub Scientifique, Pelvic Pain Matters, and Laura Rathbone for more than 20 years, helping them build their businesses and communicate what they do to their desired audiences. And I'm absolutely delighted this afternoon, to be joined by respected pain educator and my very good friend, Laura Rathbone. Afternoon, Laura.
Good afternoon. Good afternoon.
Laura is a pain specialist, clinician, and mentor to healthcare professionals worldwide. She brings a unique perspective, combining cutting edge science with compassionate and inclusive practice. So, Laura, could you tell us a little bit about your current work?
Yeah. So, yeah, I always laugh. I always find being introduced awkward and difficult, but it is lovely. Okay, so I'm a specialist physiotherapist. I work only in chronic and complex pain disorders. I work trauma and psychologically informed. And right now, I am loving my role as a sort of pine consulent physiotherapist or a sort of specialized physiotherapist allied to our local hospital here in Amsterdam, the OLVG, to their pain team. And I get to deliver their group education session, which is bringing me lots of rich reflection. But also I work with their patients individually as a kind of consultant physiotherapist, which is a role that doesn't really exist here in the Netherlands, but physiotherapists in the UK will know what kind of framework I'm referring to there. And I am a co-founder of Pain Geeks, which is an online academic skills and reading community for people really interested in learning more about pain, but also really like focusing on developing the skill of academic reading and critical thinking within and across our evidence landscape. So, for some people, it might be the first time they ever read something that's not a systematic review or a randomized control trial. Because we look at things like philosophy and humanities and how it all comes together, clinical experience, patient experiences, patient narratives, and we bring it all together in that community in a safe and warm and loving environment.
Yeah,
And
it's a lovely community.
it really is, it really is. And then in addition to that, I've been working in acceptance and commitment therapy now for like 13 years
Mm.
and been training clinicians over the last sort of 9 years in integrating acceptance and commitment therapy into their practice. So that is not much of a nutshell. It's a big nutshell, but it's it's the one I fit in. And I'm a mum of two, and which is a challenge in and of itself. And today I'm very tired because I didn't sleep last night.
We're still going to have fun, Laura.
We are, we are. But
Fantastic.
just have a disco nap later. Be all right.
Brilliant. Thank you, Laura. So just to tell you what to expect from today's session, we are focusing on therapeutic relationship, something that we all know is important, but how often do we really examine what makes it work? If you
Mm.
have done an ACT course with Laura before, this session will help to deepen your understanding of relational processes. If not, and you want to know more, we're going to be introducing Laura's upcoming ACT course, which starts in February 2026. And we'll give you details about that at the end. So for those of you who would like to know more about that, just stay on and we'll introduce you to what that's all about. And if not, you can just jump off. And do remember that the recording of this session can also be found on Laura's YouTube channel, which the link for which I've dropped into the chat, and I will drop it in again in a minute. But do like and subscribe, share with anybody that you think it might be of interest to, because we've got a growing community there too. So, okay, today we are Today we are discussing what actually creates a strong therapeutic relationship and why this matters so much in pain care. By the end of this session, you'll understand the evidence behind therapeutic relationships, the core conditions that make them work, and how contextual factors shape outcomes. So, Laura, we all talk about the therapeutic relationship as if we know what it means, but what actually is it?
Oh, yeah. I should be able to reel this off super quickly because we've prepared for this. But every time I think about the therapeutic relationship, like a firework of thoughts just happen in my mind. I think I used to think that the therapeutic relationship was that sort of being nice to the person, somehow trying to get them on board. Um, I used to use terms like getting them to buy into what I was offering in this kind of like
Mm.
marketeering perspective way as well. But I think over the years, I really don't think that's therapeutic relationship anymore. I think that is a kind of transactional relationship that we're building up there.
Mm.
One of the things that I spent a bit of time thinking about over the last few years is something that philosopher Dan Zahavi talks about. He's a phenomenologist that thinks about what it is to be human in a world of other humans, right? Um, and he says that this kind of this kind of togetherness that we're trying to build is not just from individuals observing like the same thing at the same time, this kind of like um this idea of like we're both looking at the same problem. That's not how we build a sort of togetherness. It's a kind of sharing of an approach. So it's not looking at the same problem, it's looking at each other and at the same whilst
Mm.
looking at the same problem. It's being able to have this back and forth. It's being able to sort of align with each other, um, recognizing that maybe in other partnerships, in other relationships, you might have different roles, different shared meanings, different shared like the alliance might look differently. But in this alliance, this unique one that you're building with this other person, that you will never build in the same way with anybody else because you
Mm.
are two unique individuals showing up in that moment. There needs to be a kind of calibration moment, a kind of sharing, a kind of entangling that uh, in our situation, because this is a kind of healthcare situation and it's therapeutic, we need to entangle without enmeshing, right? So we need to let
Mm.
things come together on the problem, we need to share together on the problem, without us losing ourselves in that moment. And I think that idea of we-ness is what he calls it, which I think is lovely.
Mm.
Um, it's something that we need to invest in as clinicians, which is why, and it's quite emotionally and energetically and hard work, right? So,
Mm.
and I think and when I think about this, it always sort of makes me think about Carl Rogers' sort of core conditions for a therapeutic relationship, which is this sort of unconditional positive regard from the clinician to the patient, uh,
Mm.
empathy, and this sense of sort of congruence. So in like you have to be self-congruent, not congruent with each other. I don't need to remake myself in your image. I need to be self-congruent, and then we need to find out how we can pull uh, pull our sort of ideas and our shared meaning together in this direction.
Mm.
And this what this means is that when you build this relationship, that then becomes the container for the therapy. It's the space that allows somebody to reflect, process, try new things, be afraid, sometimes maybe even well, obviously be
Mm.
vulnerable, but in some ways it might be the only time where they're able to allow themselves to have the thing, to be the thing, you know. And this sits really beautifully within an acceptance and commitment therapy framework, and trauma-informed approach as well. So I think it's not like if we learn ACT, we'll be better at therapeutic relationships. I think we need to understand what we mean by a therapeutic relationship so that we can integrate our trauma-informed and psychologically informed care into that container.
Amazing.
Yeah.
Thank you. So you mentioned Carl Rogers. Can you just break down what those core conditions actually look like in a pain consultation, so more of a practical application?
Yeah, so he the basically the sort of the three main principles, the three main conditions from the clinical side is that we have to have this unconditional positive regard. Now, this is something that I see across sort of social media. We're sort of struggling with this as clinicians because there's all this
Mm,
kind of like, um, it's always the last patient, the heart sink patient, all of this kind of like that doesn't show that we're coming with unconditional positive regard, right? We're coming in with sort of negative biases here. And this isn't for everybody, but it's certainly mimetic within our culture that I think we need to be very aware of. Um, but what it is like I'm showing up to this session um, respecting and honoring the humanity of the person that's coming in, right? And I am showing up, having done my own work so that I can sit here in non-judgment of this person in front of me. They
mm,
have lived their own life, they have been through their own challenges, they have done the best that they can, and they have managed to get into a clinic where they can advocate that for themselves, for their health, and ask for help, which I think is one of the bravest things that people do in society, right? So
mm,
it's showing up to your clinic space with that positive, like unconditional, whatever happens in this session, whatever you tell me about your life, I am going to hold judgment because I am here to help you reach your goal.
mm,
And I think that's really important in chronic pain because very often people have been through very difficult things, but especially in my clinic, maybe not in everybody that's watching this is clinic because they might be in different sort of settings, but certainly in my clinic, by the time they get to me, they've probably been through a
yeah.
lot of approaches and they might be doing things that, from a healthcare perspective would be considered risky behavior. I see a lot of people self-medicating with
Mm,
non-medical grade stuff. And they're often afraid to tell me. And the point is, I'm not there to make a judgment about that. I'm not there to be like, that's wrong. I'm there to just recognize, hey, wow, look at you, you're doing your best. And
mm,
some of this is probably working. That's why you're doing it. Some of it is probably helpful, some of it's not. Like, I'm not there to judge how they show up. I don't know if you know this, but in British doctors' letters, they would say, well dressed young gentleman, and it's like, I'm not interested in any of that stuff. Like, that's not
yeah.
how I show like unconditional regard. It's just this human being is sat in front of me with their story. So
Mm,
it's being able um, to do that without necessarily meaning that you're not allowed to have any kind of advice or perspectives or clinical opinions, right? We're allowed to, that's a different thing. Um, and then this other principle, this other core condition is empathy, which I think is a really tricky thing because I don't think we can ever really fully understand somebody else's experience, but what we're probably saying in that moment is I am prepared to try on your story enough so that I can imagine myself in that situation.
mm,
And that allows me to get a sense of the burden, the weight, the energy that's being used, the kind of journey, the to try and figure out what would it be like for me in that situation and how can I show the kind of compassion and empathy that I would want somebody to show
mm,
me to them, which is really great because when we start thinking about compassion focused therapy in this way, you can't help but start to show more self-compassion
mm,
because that's a necessary part of this process. You have to think, how would I be compassionate to myself in this situation, so that I can be compassionate to you? Oh, my camera's gone blurry. That is how I feel. So that's very accurate. Let me come back.
yeah,
Um,
that's better.
so that's what I think empathy is. It's about like trying not to disrupt their narrative. We're trying to try it on, get a sense for it so that we can walk alongside them in it, without being too careless. Yeah.
That's
And then
so
the
interesting.
yeah.
What's the most common misconception that therapists tend to have about the therapeutic relationship?
Yeah, that I think this is something that I see a lot in clinical coaching, this fear of not being liked by the patient, or this sort of like this idea of that we somehow need the first way to build a therapeutic relationship is by being nice and agreeable.
Mm,
Um, of course we're wanting to be nice to people, like I don't want to be mean to anybody, but actually the therapeutic relationship is not a friendship. It's a very
mm,
specifically a contracted relationship. That person is coming into my clinic because I have signaled that I have expert knowledge on a particular area of healthcare and that you are safe in this room. That
Mm.
means I have to hold that safety boundary. So there has to be a container there somehow. Um, so when when somebody is, you know, sometimes it might be very necessary to have really hard, very confronting, uncomfortable conversations with someone.
Mm.
For example, it might be like I had conversations recently with someone that was doing some kind of coping strategy for their pain, which put them in direct health risks. And so then you have to be able to have that conversation openly and be like, hey, look,
Mm.
we want to improve your overall health, not just your pain. And every time you do this, you're putting yourself in real significant danger. So how do we have that hard conversation?
Mm.
How do we hold a mirror up to that? And actually, what I think is really important there is we're holding our clinical integrity, and holding their healthcare as our main priority. And
Mm.
I think that's always a really important thing. Sometimes it's not always comfortable. We always want to be kind and compassionate, but it's not always comfortable. And I think that's the difference, is being able to sort of, um, yeah, hold that line. And that
Mm.
comes with this congruence that's really important in Carl Rogers' model, this idea of you can only show up as yourself. Because and as you show up as yourself, that allows the other person to decide, is this person for me or not? If you're constantly shape-shifting all the time, then that person can't make an informed decision about whether you are actually the right clinician for them, because you're
Mm.
you're masking, you're performing, it's difficult. But if you're able to show up genuinely as yourself and be like, this is the limitations of what I can do. This is my boundary here. This is who I am. I'm solid, I'm real, I'm a full person. Um, that allows the other person to then decide how close they want to come in and how not. Because this is not a friendship. This is
Yeah.
not a relationship you're building for life. This is a therapeutic relationship with a shared goal.
Yeah.
Um, and it,
That's
and,
very
and
powerful, Laura. Yeah.
yeah, yeah.
Thank you for clarifying that. So this is all great in theory, but we work in evidence-based practice.
Hmm.
So what does the research actually tell us about therapeutic relationships in pain care?
Yeah, it's great, isn't it? So, like, our evidence consistently shows that the therapeutic alliance is causally relevant in improving outcomes, and that's across like therapeutic modalities for almost everything.
Yeah.
Whether we're looking at surgery, whether we're looking at um, sports rehab, or whether we're looking at, pain care, the therapeutic alliance, and also all therapeutic modalities. So whether you're an OT, whether you're a psychologist, whether you're a physio, whether you're a medic, like how that relationship goes, the quality of the connection and the trust is not only like relevant in your positive outcomes, but it's relevant in your negative outcomes as well.
Mm.
It's so important that it is the first place we go. And we actually knew this a long time ago. So it's our nursing evidence that has really shone a light on how necessary respect and care and compassion and consideration is in how we set the necessary, like optimal therapeutic environment for change.
Mm.
So yeah, that makes me think, and I think a lot of us then think, well, is the therapeutic relationship the intervention or not? And I can get really romantic really quickly about the therapeutic relationship, because I just think that, like, I come from a nursing background as well. So like I think that the this sort of care and compassion is not just the thing we do so we can do the treatment, right? It's
Yeah.
not a transaction. It is fundamentally part of healing our wounds, whether that is a wound in the body or a wound in society. It's about
Yeah.
trust. and being able to connect in an authentic way, which seems to be important. Yeah.
That's so powerful. So if it is this important, why don't we spend more time training therapists in these relational skills?
Yeah. Yeah. It's a great question. I think we do. So I think we are building. I think it is improving, right? Like in
Mm,
my career, I've seen a change. I think our evidence is showing that we value this. Like one of the hardest things is saying you value something and then having a congruent action that demonstrates that is really important. So when I was training, we talked a lot about valuing the soft skills, but then we were never
mm,
examined on it. It was never part of how we got our points. It was never in that sort of system. There wasn't a huge amount of like respected evidence, or we weren't talking about the evidence on that because you do need to move out of a quantitative arm and into a qualitative arm. So
mm,
that's we were talking it, but we weren't using the congruent actions that demonstrated that. I do think that's changing, right? So when I did my master's, I was graded on my capacity to communicate, and I think that shows that we value this. This is not just a thing you do when you've done all of your other hard skills. It's
mm,
necessary. So I think it is changing. But I've also seen this other change where we did value it for a while and then it sort of seemed to kind of drift again. And if you want to get courses through into point systems, like you're more likely to get points for manual therapy skills. It seems to be easier to sell. I've gone all blurry again. I'm not sure why.
yeah, you could just flick it
I
off and
think
flick it
it's
back
because
on. That seems to work.
I think Zoom just knows that I haven't slept and it's like, this is how you really look. Um, so like a, but there, and I think having something where you can be like, these kind of observable, measurable things. Like you go in, you learn how to do a technique, you show the
Mm,
technique, you get examined on the technique. It somehow has this more like tangible feeling to it. So I think that that's probably why we don't do as much, or we don't focus on, or it doesn't feel like we focus on it as much. But there was some lovely ACT evidence that came out ages ago, and it's probably been followed up a few times as well, that looked at when you teach physiotherapists acceptance and commitment therapy, like what's their like subjective experience of being a therapist, and they
mm,
are more able to handle the complexity of experience that the patient shows up with. They are more
yeah.
confident, they don't feel as panicked, they're more able to do so this is something that can be trained, right? It's not inherent to the personality of the person, and by the way, they're usually feminized, right? It's because there's like this idea that only women can care, and that's absolute bollocks because all human beings have this capacity to do it. It's not inherent. It's something you can train, you can get better at it, and it will make your job easier and
Mm.
also help you to connect with patients in more meaningful ways, which I think is wonderful.
Thank you. Amazing. I'm just conscious of our timings, and
Sorry.
so we've got a couple more questions and there's I've just picked out a couple of the key ones I think that clinicians will be most interested in.
Mhm.
So if we're to talk about, I love the way we talk about this, and in a perfect world, you know,
Mm,
you've got tons of time,
yeah,
and you can think about all these things. But the reality is that we don't work in a perfect world.
no.
So, and could you just quickly go through the contextual factors that impact a clinician's ability to create these relationships? And then the bit which I think is probably key is the how do you do that in a 20-minute appointment?
Right, okay. So I am going to probably be at my most controversial in this moment, and I'm going to call bullshit on all of that. Right? There are, without a doubt, there are systemic level factors in terms of time, administration load, productivity
Mm,
targets. All of this is absolutely there. Lack of continuity is a really big problem when people see therapists as interchangeable. We are not. You start with one, you finish with one. That's how it should be. Sociocultural factors. So like there's like power play all the time, and the physio sometimes or the therapist is sometimes the middle man, middle person in between these sort of shifting tides of power, right? So you've got managers, you've got clinic owners, you've got colleagues, you've got patients. All of this is sort of making it very difficult. I get that. Then you've also got your own life, right? So you might
Mm.
be going through a divorce, you might be going through a long-term, learning to live with a long-term condition. There might be all of those things. They will absolutely have an impact on how you are able to show up in your job and look after yourself. And I want clinicians to be really good at
Mm.
noticing that so that they can take the time for themselves. But this idea that building a therapeutic alliance requires enormous amounts of time and no systemic barriers, I think is a bit of bullshit that we feed ourselves all the time. You can make a therapeutic alliance in, you can start building it as soon as you start talking to your patient. And we have to remember that it doesn't happen in the one session. It takes
Yeah.
time. People are going to come back. They're going to test that relationship, check it. They're going to challenge it, they're going to push it, ask questions, see how you respond to all of that. It's over time that you're going to build and deepen and strengthen that bond. So
Mm.
maybe we need to be more comfortable with that. But also, it's not like, I think it's about being honest. If you've got systemic barriers, be open about that. Like,
Yeah.
sometimes I have patients come through with some of the most complex situations I have actually ever seen. And they might say, I've only got 3 sessions. And I'm like, well, then you've only got 3 sessions. So
Yeah.
that is a limitation. I cannot overcome that limitation. So I can't overpromise what we can deliver. I know we're not going to deliver a great period of therapy in those 3 sessions. The patient
Mm.
knows it. Let's be honest about it. And the more honest we are, the more the congruence we're going to build and collaboration we're going to build. I don't think we need loads of time for that. I just think we
Yeah.
need to be brave. Like I've said in
Yeah.
many sessions, we've got to be able to say, to let people down, because that relationship will survive if there is trust and if there is integrity on both sides. I could
Yeah.
say like, I am pushed. I've got, I'm really sorry, there's time constraints and I can't do the thing that we need to do. Or I've sometimes like I don't have all of my equipment with me and I have to be like, oh, I really wanted us to do this thing, but I've actually forgotten that thing today. So can we do something else? Like it's okay to be human and it's necessary in order to
Mm.
build a therapeutic relationship. It's when we're pretending to be something else that we create fragility and delicate, and it becomes delicate then. And that's when we become afraid to step out of into different directions or to challenge or to hold up a mirror because we're so afraid of it breaking.
Okay. That's fantastic. Thank you. I think it's really important to point. I've just dropped a few bullet points into the chat there
Mm.
just to summarize what you were saying, because I think that's a really important point for people to take away. So I think what we'll do is we'll do a sort of bring it together question. We've talked about Rogers, we've talked about evidence, we've talked about context. Can you just give us an example of what this looks like using ACT principles to navigate a challenging relational moment? We love an example.
Yeah, and I have to be careful because obviously I want to try and give like caricatures of patients, not and make sure like, and if any patients do watch this and see themselves in this, remember, I'm not talking about your individual cases. It's a mixture of patients that I've seen over time. Um, I think one of the things that's really important is to first of all notice if there is tension in the relationship and be able to name that because sometimes you get into a situation, and I've had it recently with a patient of mine who actually chose to stop therapy with me early, which I always respect enormously because I think good for you. That is a huge sign of agency and self-advocacy. But we just were aware really quickly that we were really struggling to sort of come together for some reason. We were both nice people, lovely patient,
Mm.
really open, but for whatever reason, this just wasn't connecting. And we did a really good job of labeling that in the beginning and just being like, yeah, what's going on here? This doesn't, what's happening? And and then we sort of recontracted and we were like, hey, what do you want to do? Do you want to keep going? And he was really like, I'm happy to keep trying this, but it
Mm.
does feel off. And I was like, lovely. Let's keep going. Like, see what happens because it doesn't have to be perfect to be helpful, right? And you're not
Mm.
always going to have this amazing relationship with your patients where, you're laughing and giggling. I don't know what's going on. Sometimes you're having a relationship with your patients that's like, a little bit distanced and it's a little bit clangy and a little bit like that. But being able to open that up into the space then actually, ironically, builds a stronger therapeutic alliance.
Yeah.
Um, so I think sometimes that can be a very helpful, and I'm speaking specifically to the therapeutic alliance, but there's going to be loads of other examples that's not about the connection. It's about um, like, you've made a mistake and being able to label that, or um, they are doing something that you think might be getting in the way and counterproductive to the therapeutic process, which I think is the one
Mm.
we're the most afraid of. Like, I know I am
Mm.
when I see someone and I'm like, huh, you're doing that thing again that I think we were already identified as unhelpful. Do you notice that you're doing it? And being able to hold that mirror up, even when sometimes we know the other person isn't going to like what they see.
Mm.
Um, and doing it in a way that is not like punishment or shaming, but in a sort of like, yeah, I know, because when I have this mirror held up to me, I'm like, "Ooh, oh, I know I'm doing it. I don't want to
That's
do it."
everybody.
Yeah, I know. But isn't that the role of therapy, right?
It is.
Sometimes the point is not just to put more in, it's to say, hey, what you're already doing, some of that maybe we need to try and see if we can let go of it and
Yeah.
do things in a different way. Um, and I think that can be really, really challenging, but it is
Mm.
absolutely our job. That's the contract. Yeah. And every time we do
Amazing.
that, I think we build trust, even if we're wildly off. Like I've had a patient just be like, no, I
Thank
don't think
you,
that
Laura.
speaks to my
You,
experience. Um, but it's yeah, it's helpful nonetheless. Yeah. Sorry. I'm not sure what happened then.
okay, fantastic. Thank you. Now you just paused a bit. I think maybe it may be connection issues or something.
Yeah.
Okay, so we're just going to wrap up now, and in a minute, I'm just going to ask Laura to give us a sort of key takeaway from today's session. But before I do that, I'm just going to just mention Laura's ACT course.
Mhm.
She has a an ACT course coming up in 2026 in February. It starts on the 3rd of February, and for anybody that is interested in exploring these concepts that Laura's just touched on today more deeply to develop your ACT informed practice, then you may well be interested in attending that course. It's online and it comes with a whole package of supported resources, including focus work on therapeutic relationships and relational process. So
Mm.
I've dropped the link to the chat there. There is an early bird discount which ends on the 30th of December. So
Yeah.
if you are interested in joining that, you might as well get in early and get the cheaper rate. So Laura, is there anything that you just want to share with the audience about the ACT course and what they will come away with if they were to attend an ACT course with you?
Yeah. So I think what I'm really proud of about the ACT course and what I've heard from participants over the years is that have gone on then to make ripples in their own communities, which is wonderful.
Mm.
Um, is that I think so I do value the therapeutic relationship. I do value this sense of community. That's why Pain Geeks is something that I sort of envisioned for
Mm.
for our community. It's about bringing together and building safe spaces for learning. So what people will experience is this sort of deeper connection with the other participants that are there because that's what makes learning easy, right? If you feel
Mm.
safe enough to be vulnerable and ask the difficult questions and say the thing that you think is stupid in your mind, like you're going to be able to learn more comfortably and at a higher rate and it's going to stick for longer. You're going to be able to do the sort of role play and really throw yourself into it because you know that you're safe and you're around people that aren't going to judge you for that. So that's a really important part of the ACT in the clinic sort of um, I guess, principle or philosophy
Mm.
is that it's like it's us first, the learning comes through that. Like it's got to be a we, there's got to be a we there first. Um, and that's why, like, and this learning is also, it's part of career long learning, a bit like therapy. Like you might see that patient for sort of 6 sessions, but they're going to take that on further and do stuff with the conversations you had that you have no capacity to imagine right now. And that's exactly the same with the participants on the course. Like how far I can take ACT is just how far I can take it. But I've
Mm,
looked at some of these participants and they've gone on and taken it into much bigger rooms than I've been able to get into. And I think that is amazing. So it's career long learning, and it is hopefully about really deepening the roots of the knowledge so that you can make it into your own. And that's what I focus on in the course.
amazing. Thank you so much.
You're welcome.
Parting words. What would you like somebody to take away from today's session
Yeah.
about the therapeutic relationships in pain care? What would you want it to be?
Yeah, I think that we have to invest a little bit of me in order to make a we, and we also have to give space for the you, right? So it's not about a me and a you coming together, it's about me and you forming a we in between. So there's
Mm,
going to be bits of us that come in and that's going to take energy and it's going to take time. So we have to build systems that look after us because as therapists, that is our role. Um, so look after yourself in that so that you can show up for the other person that's about to walk through your door, and then the one that comes
amazing.
in after that, and then the one that comes in after that, and then the one that comes in, and that's it, right?
Yeah.
So really value your health and your well-being.
Thank you.
Yeah.
Thank you so much, Laura, once again. It goes so quickly. There's so much in here to learn. This is the fourth webinar in a series of
Yeah.
ACT Essentials.
Yeah.
Please do jump into Laura's YouTube channel, check out the other videos, like and subscribe and share the videos.
Yes.
And we thank you for joining us live today. And anybody that's watching on replay, thank you very much for watching. Take
Yeah.
care and have a
Bye.
good rest of your day. Thanks,
You.
Laura. See you next
Bye.
time. Bye.